So this reinforces that we need to get as much PrEP out there as possible, as it has an impact. However, we're not at normalization, so PrEP isn't accepted and accessible for all people, so there is still work to do. And local partners are critical to this work. Quarter over quarter, local partners are making up an increasing proportion of PrEP results. In FY22, just through Q3, local partners initiated over 333,000 clients onto PrEP, surpassing the target. And in FY22, as of Q3, LPs made up 64% of PrEP new results. And actually in FY23, LPs will hold 70% of PrEP new target share. So LPs will really lead PEPFAR in contributing to the global 2025 goal of 10 million people on PrEP. So I'm going to hand over to Laura to introduce our panel.
Thank you, Allison. Welcome, everyone. It is now my pleasure to introduce to you our first panelist, Dr. Veni Naidu from South Africa. Veni is the HIV Community Service Lead for Broadreach. She has been working on the DREAMS program since 2019, providing technical support at national and district levels. She has vast community level experience, and we are so excited to hear from her now. Dr. Veni.
Thank you very much. Good afternoon, everyone. So our topic this afternoon is on increasing oral PrEP initiations among adolescent girls and young women from South Africa through co-planning and co-location activities with our DREAMS community partners. I'm sorry, I'm competing with the ice cream person outside. Okay, shall I go ahead? Okay, thanks. Shall I just wait? Okay, thank you. Okay, thanks very much. So you can see my topic on the screen. I'd just like to take this opportunity of acknowledging my co-authors from Broadreach and also from the Department of Health. So adolescent girls and young women in South Africa are at a significant risk of HIV acquisition and is therefore a target population for HIV prevention. According to a recent study done by the Human Sciences Research Council, the HIV incidence in South Africa is around 1.5% every week, resulting in about 1,300 new infections. So Broadreach, in partnership with the Department of Health, since October 2019, we started the initiative of DREAMS, where we started to initiate on PrEP. So oral PrEP initiations have been suboptimal due to various factors, including challenges in getting AGYW to come to the facilities. As you know, that they are mainly found in the community and prefer services where they are. So today our discussion is going to be around the implementation and also the outcomes of co-planning and co-locating activities with our community partners to increase our PrEP initiations. So there are various factors that we found contributing to low PrEP uptake, and these factors we found during our consultations with AGYW. They generally have fear of judgment, whether it is from their parents, from their peers, and also from the healthcare workers themselves. They also find the health facilities not being conveniently opened to suit their purpose, and they have some reluctance in taking medication. They have also exposed to substance abuse and to gender-based violence. So how did we go about with this intervention? We firstly, the co-location strategy for us started in 2021 in 4 Broadreach supported districts, and that is King Sitshwayo and Ugu in KwaZulu-Natal, and Karsabandi and Inkangala in Mpumalanga. So we did joint planning with the Department of Health and local partners, whether they are DREAMS partners and also non-DREAMS partners. And we've used a project management approach. In terms of having the attendance and collaboration, we worked very well with the various stakeholders where we did the planning together. And the venues that we used were mainly tertiary education centers, schools, and community halls. And the services that we provided, apart from healthcare, we did also community partners assisted with providing life skills, social asset building. We created, there were problem-solving skills that were imparted, and also economic strengthening activities. In terms of healthcare, we did HTS, same-day PrEP initiation. We did linkages to care. There was contraceptives and contraceptive counseling that was provided, and also lubricants where it was available when we worked with our community-based partners. We also did GBV screening and also mental health screening and referral. So it was a very holistic approach with comprehensive services that was provided at these co-location events. So how did we create demand? There were two types of campaigns. There was one organized by government departments, and there were one organized by DREAMS partners. So in either way, there was a lot of marketing that took place with loud hailers and posters and whether they be at community meetings, there were announcements, and also there were radio community spots that was made available. And interesting enough, during sporting events, there was a slot being provided where announcements can be made of the forthcoming community event. And then in terms of the DREAMS partners, we did a lot of peer youth facilitation at schools. We also used clinic groundbreakers making announcements in the health facilities. There was exposure to MTV media, and also through our school health programs where the announcements are made via the school principals to the children. And then, of course, during life skills program sessions. The important thing to note is that all partners, whether you were DREAMS or non-DREAMS partners, we all use the DOH PrEP guidelines so that we have standardized messaging that went out. So how did we cope with continuation and sustainability of PrEP? After initiation, we would follow up a patient 2 weeks later to check for side effects and also to remind them of their appointments. We did a 1 month follow-up for PrEP refill, and clients who failed to return, we did tracking and tracing via WhatsApp or SMSs. We had community tracing teams track those who could not be contacted. And of course, I'm sure you also have experienced that there are many challenges, especially if you are initiating in the community and trying to bring patients back to the facility. So in terms of our results with the co-location and co-planning, we in the first quarter, the results from PrEP initiations amounted to about 5% of total PrEP initiations for quarter one, and by quarter three, it represented 18% of all PrEP initiations came from the community. So it was really for us a success to work together with community partners. The important thing to note is that we used a project management approach to planning these events. So we had a project plan schedule, the stakeholders were mapped and engaged with, commodities were put together by the Department of Health who assisted, and then of course it was important for us to make sure that we collect data, that we share the data that we collect, and we did that via a standardized tool. We signed referral slips. Of course, we had the same day initiation, which really helped. And then, of course, the data was used again at the end for debriefing sessions to discuss any challenges and successes. So just to share with you some of the tools that we used, the project management template consisted of key activities, the deliverables, the timing. We also had responsible persons and organization, and we had progress on key activities, and then, of course, if there was any action that was delayed, we would have some mitigation and we would have some discussion on that. Just to note also that these activities were very short-term based. So we had many of these co-planning, events, co-located events, and they were done on a weekly basis. So there was lots and lots of follow-up and lots of project plans. And this is what the standardized reporting template looked like. As a DSP, we brought all partners together and we developed these reporting tools where we collated the data at a district level and shared it not only with the Department of Health, but with all partners so that we can learn from it, from each event, and use it for our future planning as well. So just then in conclusion, we work in these two provinces, KwaZulu-Natal and Mpumalanga province, and we work very closely with the Departments of Health in both of these provinces. We did have same-day initiation, and of course the co-planning helps with having the linkages done almost immediately to the other community partners, and also linkages back to the facility. We found that co-planning and co-locating is an effective HIV prevention strategy to increase the PrEP uptake and awareness amongst AGYW. But important also is the project management approach, which led to a successful implementation. Thank you.
Thank you so much, Dr. Benny. For anyone that has questions or comments, we are going to take them at the end, so keep track of them. And now we are moving on to our second presentation. It is my pleasure to take us to Vietnam with Dr. Ruben Frescas, who is a board-certified doctor in family medicine with an MPH, working as the Deputy Chief of Party for the USAID Ladders Project at the Life Center. He also supported WHO as a consultant, and prior to that, held a faculty position at Johns Hopkins Medicine. Welcome, Dr. Ruben. Thank you.
Hello, everybody. Thank you. It's a pleasure to be representing the team from Mozambique and sharing the experience that we have had in the development of the IntraHealth application, which is an application meant to bring services and empowering clients to manage and navigate their care. What we did in Mozambique was we were trying to assess and look at, in Vietnam, sorry, was look at the issues with trying to expand outreach, improve health literacy among clients that we were working with, and empower those communities to be aware of the services in which they would most benefit from. And in Vietnam, the contingency or the population most burdened with HIV is among key populations, and particularly among MSM. So the solution that the team had integrated and utilized was the IntraHealth application that the project was already using to help monitor and track some of the metrics and some of the data inputs from the community, but then trying to optimize this in order to bring information to the palm of clients' hands so that they have that information accessible to them anywhere at any time. So the version 1.0 of this application that was developed, as I had mentioned, was primarily used for data entry and data monitoring of outreach worker activity at the community, and providing some general information for clients to know about different kinds of services such as HIV testing, sexually transmitted infections, mental health, substance abuse, et cetera. What we had worked with is integrating and updating this to the 2.0 version, which is now a more integrated and interactive version of the application that will allow clients to directly schedule appointments with community-based organizations, order self-tests so that they can be brought to their location of convenience, as well as offer an array of different services through a facilitated approach online that allows the user to engage in the privacy of their own home. The additional function that we have upgraded the system to is also looking at the database of information that goes into the system and looking at client profiles, so looking at the characteristics of client information in order to help inform communications campaigns, the messaging that goes into those campaigns, various outreach approaches, whether they be live events, online events, individual and group counseling techniques for specific subgroups that best meets the messaging targeting for them, and then anticipating enhanced support for particularly vulnerable populations. In other words, if we're looking at populations that are most at risk for loss to follow-up or difficulty with linkage, who are they, and what are the messages that best support them in order to mitigate those issues early on? Should mention that this is a tool. This is a tool integrated within a larger strategy. Another strategy that we actually have a poster out on the gallery is this community one-stop shop model, which we call the DOME model. It's previed on 6 pillars or 6 steps that are applicable to a number of different health services that include outreach, counseling, screening, testing, referral, and support. And in the subsequent slides, I'll show how that approach is integrated with this online one-stop shop approach. The other things just to highlight about this particular model is it does try to standardize the approach of how community-based organizations interact and engage to provide these services in the community, accountability to make sure that the provision of the SOPs are abided to, as well as branding. So when a client goes to one CBO or to another CBO, they'll recognize the branding and know that the quality of the service and the service being rendered will be equivalent no matter which location that they had chosen to go to. And then the last part, which is probably one of the more important parts of the model, is the business development for sustainability. So building the capacity of community-based organizations in order to find additional funding revenues in order to sustain their operations and needs beyond the dependence on external donor funding. So these are the 6 different pillars acclimated into the online one-stop shop model. You'll see that there's 3 distinct phases as to how the digital platform accounts for these 6 different steps. The first 2 are accessible to anyone who downloads the application. This will allow people to see information on a number of different health services, whether they be HIV, sexually transmitted infections, mental health, hepatitis. However, once you start getting into applications where you start interacting and engaging your own personal information in, then we do require that you have a profile addressed. This, however, allows us to start building that database of client characteristics, client behaviors, client preferences, in order to identify what are the screen positive behaviors that we're seeing among different groups. From there, the screening assessment tool will then allow or recommend whether testing is appropriate for that particular disease that they've engaged in. And if there is testing available at the community, whether it be HIV testing or whether it be STI screening that our CBOs also do in the community. From there, appropriate referrals are sent for care and treatment at our partner health facilities through another model that we engage with, which is the C2P, which we'll talk about during a panel tomorrow. And then the last step is support. So, for example, if we do have a client that undergoes testing, they may have screened negative for HIV, but are still a client that would benefit from PrEP, for example, they would be referred for PrEP, and then additional support would be provided to make sure that they understand side effects as they initiate PrEP treatment, for example, and then provide additional support in order for them to maintain PrEP for as long as they need. So I'm just going to highlight some of the milestones in the development process for the application. So the planning phase of the application involves looking at the interfaces. So what does the client see? What does the outreach worker see? What does the administrator see on their respective screens, the variables that they put in and how they engage with it, as well as the database. What are the various variables being brought into the system that we will later analyze and look at? From there, we then develop the wireframe, the layout, and the design. These are the elements that are needed then to build the mock-up pages, which would be the pages that would eventually build each individual application feature. Currently, we're in the alpha test version of the application. That means that it's a controlled testing environment where we're able to look at the flow, the function, the content, the layouts within the actual platform. From there, we will be moving to the beta version, which is engaging with actual end users to provide feedback and to make final refinements and modifications for the public launch later this year. Just to iterate that right now it's a very iterative process, so even though you have initial plans, layouts made, once you actually put it into the actual platform itself, you may have to work around and reconfigure it as well. So it's a very fluid process in its development. This slide I just wanted to show to illustrate that it's also important to look at who are the stakeholders that are engaging and using the system, and what is the data that's being transmitted, and how does that work between different stakeholders. So having this understanding and mapping will allow us to better understand user behavior, as well as look and analyze the data that comes from the use. What I'm going to do is just highlight the example of how an end user would use the application in the PrEP module, for example. So here we see the home page for the application. If I scroll down, you'll see there's an advertisement there for event-driven PrEP, for example. And then if I scroll down further, you can see there are two boxes there that allow me to either choose a service from a different menu of services, or there's a simple algorithm that asks 3 questions that will initiate and begin your journey in the online health facilitated process. So if I were to click on the health services down here, that'll bring me to the subsequent page where I can choose a number of different services here, whether it be HIV testing, PrEP, or PEP, for example. Or if this becomes too overwhelming for me as a user, again, I can click right up here and start with answering 3 simple questions to help risk stratify which service may be most applicable to me. So if I went that route there, the alert window will pop up and recommend which services I can start with first. So here, for example, if I was to go with the PrEP response following the simple algorithm, it would then take me to the PrEP page. Here I can scroll through and read a little bit more about what PrEP is. We have some of the highlights. We have also produced a video that will take the user through what PrEP is and how do you use it. And then we also have a screening questionnaire that allows the user to know is PrEP something that would be particularly beneficial for me. This does require that the user has a profile created, so if they don't have one when they click that, they will be prompted to sign up and register their profile. From there, they will answer a handful of screening questions, and depending on how the screener stratifies the responses of the responder, then there's a recommendation whether PrEP is encouraged for the client to take. In this case, it is, so you click the next button, and this allows you to schedule an appointment with a community-based organization to then help support you in linking and enrolling you onto PrEP. So from here, once you actually engage and roll onto PrEP, the next step of the process is the support. So here you provide some information about the use of PrEP, some of the common side effects encountered with PrEP, and then finally additional services that the client can also explore further in the application. So there's a whole array of services that the app encompasses all in one place, which is our one-stop shop online approach and model. So thank you very much. Come on.
Thank you, Ruben, for sharing that innovation. We are holding your questions. One more presentation to go. We are heading to Botswana with Dr. Botlale Mosadame, who is a medical doctor with over 6 years of experience in the public setting. She holds an MBBS degree from the University of the West Indies and a postgraduate certificate in sexual reproductive medicine from the University of South Wales. Currently, she is working for Tebelopele Clinic and supporting Gaborone and Quenning East Clinic. Welcome, Botale.
Good afternoon, everybody. Thank you for the very warm welcome. So today, I'm going to be talking about I don't know if they can hear me because I am a bit short, but I hope everybody can hear me. Today we'll be talking about optimizing PrEP service delivery amongst the adolescent girls and young women in the Tebelopele Wellness Clinics, that is to improve uptake and continuation. But prior to me starting, I would just like to acknowledge in absentia the originator of this abstract who was unable to join us. I stepped in at the 11th hour, and thank you so much to the team for helping me to arrive here today, as well as to the Gaborone team who I know are watching right now who make all of this possible. So it said, my name is Dr. Botlhale. I'm the medical doctor at the Tebelopele Wellness Clinic. So let me give you a little bit of a background about Botswana. Botswana is just north of South Africa. By flight, it's about 55 minutes. By driving, it's about 5 hours from here. Now, Tebelopele, or rather in Botswana, our annual incidence of HIV amongst the adults aged 15 to 64 years was about 0.2, which corresponds to about 2,200 new cases of HIV per year amongst adults. And HIV incidence amongst females was 0.4% and 0.0 amongst males. The HIV prevalence amongst people aged 15 to 64 is 20.8%, and the minority of them are men, being 15.2%, and the majority are female, making up 26.2%. So we recently completed the bias study, which is basically a study that aims to survey the impact of HIV/AIDS in Botswana, and it was recently completed in 2022, and it showed that the prevalence amongst people who are aged 15 to 19 is at 2.7%. One would think those numbers are small, but remember, we are a very small nation, so 2.7% actually contributes a lot to our very small population. By 5-year age groups, HIV prevalence was higher amongst the females, and was higher amongst females than males in each group from ages 20 to 24. So this is basically a landscape of what the country looks like. And as we continue our background, the Kgatelopele mo Botsogong project, just to give you, for those who don't understand Setswana, the name Tebelopele actually means looking forward, like walking forward, go lebela pele. And the name Kgatelopele mo Botsogong means walking together, like walking together in health. So these names really tie into the context of what HIV was like, because when Tebelopele was founded, there was no hope in terms of ARVs, and people were really dying a lot from HIV. So we're really looking forward to a better future. And indeed, right now, when we're talking about PrEP is indeed the future. We're walking together towards the future. So with Kgatelopele mo Botsogong, we have about 3 districts. That is the Gaborone, this capital city, Queneng East, which is south, and then Francistown, which is north of the capital city. So the project aims to provide a client-centered, integrated HIV health services to close the gaps related to HIV/AIDS prevention and care and treatment among adolescent girls and young women. Our target population is the 10 to 4, the AGYW. We talked about the Dream Girls. We also talk about the men who are 25 and over, as well as females 25 to 39. It's a combination prevention package for AGYW. The previous presenter did talk about a one-stop model, and I'm glad to say that also in Tebelopele we implement the one-stop model, the entry point being HIV testing, because Tebelopele is known as the HIV testing center in the entire country. So we have a package for the adolescent girls and young women. Pre-exposure prophylaxis being the key emphasis, HIV testing the entry point, STI screening and treatment, a contraceptive mix, condom education and distribution, post-gender-based violence care identification and clinical care, referral for primary service, that is the social asset building services, such as for financial literacy, and as well as the online platforms. We have a Cookie Jar Facebook group, which is a closed space for our young girls to interact and get knowledge that is evidence-based related to sexual reproductive health. So when we talk about the theory of change, in 2016, Botswana had the HIV guidelines, and amongst the guidelines being treat all, as we all know, they also recommended the use of PrEP. So again in 2018, in 2018, Developile Wellness Clinic pioneered PrEP services for the at-risk population, including our adolescent girls and young women. But we did face a lot of challenges. There was stigma surrounding, taking PrEP, because people, once they heard that PrEP was an ARV, there are negative connotations in the country with regards to taking an ARV pill. So people felt that maybe they were getting stigmatized. Some people thought that by taking this pill, maybe you actually have HIV, and they didn't want to disclose to people. The side effects, of course, some of the patients experience some side effects, and we all know them. Despite counseling, some clients would still leave PrEP because they were not able to stand the side effects. Poor perception of HIV vulnerability. They don't understand actually that they are at risk. They are at-risk population because of some barriers in education, etc. High mobility. In Gaborone, for example, where I work, it is the educational center for the country. So a lot of young girls are moving from their rural areas into the urban areas to come and get this tertiary education. And we are very centralized. Most of the universities are centered in one area. So when the schools close, they go back into the villages, and we would lose them in that transition period. And also because people do have a rural-urban migration where they come to the cities for the jobs, as well as urban-rural where they don't have jobs and they go back into the rural areas. And as part of our mitigation plan, we did a lot of education on PrEP, including the side effects. We did appointment reminders through WhatsApp. We also did booking systems for them where they would come into the center on their dates. We'd also have a case manager who would call them to remind them of their appointment. But still, we realized that there was still that challenge. So in 2021, we scaled up the PrEP services for the adolescent girls and young women, including our community outreaches. The challenges were, of course, again, centralization of services. We realized that girls were simply not coming into the facility to come and get PrEP. They know about PrEP. We educated them about PrEP, but they're not coming into the facilities. Again, high mobility being one of the reasons, as well as some of the side effects. So we decided as a team to decentralize the PrEP services for our AGYW, and we marketed these decentralization of the services through the different digital platforms. We have our Facebook page, as well as the Cookie Jar page, where a lot of the young girls are being found. So how do we implement? We have a facility-based implementation. Of course, our walk-in clients, as I said, Developile is a walk-in facility. People know Developile for HIV testing. They actually do prefer coming over other, for example, government facilities. We are known for testing. We get referrals by others where people know about PrEP and they refer their friends for PrEP. Through the implementing partners, because strengthening of partners in a community is very important, because it works better if you work as a team. So they refer our clients to come and get PrEP from the facility, because we are facility-based. And of course, we have our community-based implementation. We partnered with the tertiary schools, as I mentioned before. We have our one-stop shop model with the other partners, the DREAMS partners, the other implementing partners for DREAMS. This was done again through outreach activities, appointment reminders. We have our mobile clinic, which is all the 3 centers have a mobile clinic where they actually go into these spaces and they give the girls the services. For example, in the Gweneng East, they travel with their mobile clinic as far as maybe 150 kilometers to go and give these girls the services where they need them. So our methods, of course, we had our district level planning. In Botswana, we have the district management team. So we integrate into their activities in order to implement this model. And then our partner-to-partner planning, memorandum of understanding with other universities, community sensitization, and multi-month dispensing. So this is basically our data from October 1st, 2021 to June 1st, 2022. And it actually showed that 74% of our initiations were done in the community and only 26% were being done in the facility. This is an example of what you're seeing. This is actually at the University of Botswana, the biggest university in the country. And this is our mobile clinic. We go every Wednesdays and Thursday. We set up, and here are the girls lining up for services. When it comes to our PrEP continuation, number of individuals, excluding those who are newly enrolled, who return for a follow-up visit or reinitiation. So initially, as I said, this was actually in the first quarter where we realized our girls were not coming back for PrEP. So you realize that we were actually not even able to reach our target in the first quarter. So we did a lot of these implementation measures, and it actually showed that the girls were taking PrEP in the community. So as a result, by Q3, we noticed that 73% of our refills were being done in the community, which is a first for PrEP CT, because we are the first to implement PrEP CT. So the lessons learned and the conclusion: successful PrEP scale up for our adolescent girls and young girls in Botswana requires integration into the young girls' daily lives. As young women, people are living very busy lives where they can't actually walk into a facility. So we need to integrate this into their daily lives, as even the previous speakers even talked about. In conclusion, scale-up of PrEP requires decentralization to improve access and to allow continuity in PrEP. Thank you very much.
Thank you so much, Botlale. I'm feeling very inspired by this panel. Can we get one more round of applause for such an amazing panel? Thank you so much. We now have 12 and a half minutes and would really like to open it up to everyone that's in the audience. If you have questions, if you have encouragement, we would love to hear from you. There's one in the back. I think we have a microphone here that we can run around with. Hello? Hello? Hi. Okay.
Giovanni, USAID Guatemala, to Ruben in Vietnam. What is the coverage of the estimated size population that download the application? Not the number of users, but the coverage of the size estimation population that download the application, and what is the percentage of the users who pass from the first screen to the second one?
Thank you for your question. Just to clarify, the presentation on the update for the users to actually use the features that I had mentioned still has yet to go live. The use of the current application is on general information and some of the initial data screens that we have done. But those that do the screening test, at least on the version 1.0 that we have on the application, the last numbers I had seen were roughly 80% of those that did the screen actually came out with a positive screen for the particular disease of interest that they were testing for through the screen process. So this highlighted to us that people are actually accessing things for risks that are actually reciprocated in their use day to day. So the value of empowering clients with having the reassurance of being able to tip their behavior to actually go on to that next step of committing to do a test or follow-up is rather significant.
I think mine is South Africa. Yeah, I just wanted to find out with regard to community tracking teams, who is on the tracking team, and what is your success rate for retaining?
Go ahead.
Yeah, thank you
for the question. Yeah, we do have community tracking teams within Broadreach, but we also work with our Dreams partners and our OVC partners who do door-to-door home visits to track and bring back patients to care. And we have recently implemented a linkage tracking register, and we are following up on those patients and receiving feedback. As you know, feedback sometimes, in the beginning when we first started with the implementation, it was lacking, but we're seeing great improvements now. And we also work with community health workers to assist with the community tracking tracing.
Thank you. My name is Byron from Zimbabwe. I would want to maybe seek clarity on two issues. The first is for Dr. Naidu with the PrEP program in South Africa. So we have a similar program, and we noted stigma was a major issue with PrEP, particularly for adolescent girls and young women. So I noted in your demand creation activities, you were using large haulers and like public platforms that would talk about PrEP. I want to understand the messaging that you used and how that impacted uptake. Remember, this 16-year-old is a mother who listens to this on radio. When she then picks that blue bottle in the girl's bedroom, she knows that the girl is having sex. How did that then affect the uptake of PrEP, and how did you maneuver around it? Sorry, I missed your name, Botswana team. Your PrEP CT was quite impressive. We have sort of not so identical outputs with our Zimbabwean program. Our continuation of treatment is quite not so good, mainly because people screen in and out in terms of risk. You quoted 73% community level and a 21% facility. I would want to understand, was that 1 month? Was that fourth month? Was that 7th month? Remember the supplies, and how did that also relate to these girls going back home with their parents back in the village, so the risk is low? Did they then continue to take the PrEP, or did they stop? And how did you account for that in your reporting to come up with the 73%? Thank you.
Thank you. We'll give the response, time for response.
Okay, thank you for that. So I'll respond about the stigma and the messaging. So we use very standardized messaging that's developed by the Department of Health. And we try to be very positive in the messaging, to give young girls a choice that, when they are sexually active, then they do have a choice, and PrEP is a prevention choice. And we don't just offer PrEP on its own. There are various services, comprehensive services that we do offer with the PrEP. So, we don't sort of like zone in on all the vulnerabilities or scare them about it, but we explain to them sexual relationships and so on. And so there are also in groups, so it's not just the loud hailing is about advertising the event itself, but we don't loud hail about PrEP messaging. So those messaging is done in a very organized, in small groups or at individual level. But the event itself is marketed on a larger scale. So when the clients come to the venue, that's when we go through our very standardized messaging and counseling, and all of that has to be very done in a very sensitive way. And we also educate just beyond the client itself, but also the parents, the male sexual partners. So we try to bring all the different players into the counseling as well.
Okay, thank you so much for that question. There's a lot that we do in our centers to ensure that the girls do stay on PrEP. One, I did talk about our community partners. Because we are facility-based, we don't have the ability to actually go door to door. Our licensing doesn't allow. So we have worked with our community partners who do the door-to-door mobilization. They know where these people, where these girls live, especially in the villages. So we partner up with them. When they mobilize, we enroll, we initiate, and we give PrEP refill and review. with PrEP, education is the key. We really we have a tool that we use to assess their PrEP eligibility. And when you are counseling the girl, of course, girls do cycle on and off PrEP. It's a worldwide problem. But we educate them a lot about the importance of what is your risk. Am I having my boyfriend is, you know, I'm not really seeing what's going on with him, and I think he might be cheating around, and, you know, PrEP is the best solution for you, and we try to really educate them. I can't emphasize the importance of education, because if your clients don't understand what they're taking, they're not going to take it. And then, of course, we use our appointment system. So when we go into these places, we have an appointment system. For example, like I said, every Wednesday and Thursday, we're in University of Botswana. In the villages, for example, when in Easter, they circle around the villages where these villages, they don't have access to some of these services. So we ensure that when their time comes, we're back again to refill for them. So if I'm in Harare, I'll just give an example because you can identify with Harare. We go to Harare on the 21st. We ensure that when it's time again the next month on the 21st, we're there again. And of course, the other thing that I didn't talk about is in Developele, we actually have non-branded vehicles that we use. It's a strategy that we're using to ensure that our girls, maybe they don't feel discriminated, because there is that issue of you coming in with a big van written Developele USAID. Obviously, you are coming to do something with HIV. So we have a small little car that we use on a day-to-day basis. So the teams are like this every day. We have one nurse staying into the facility. The other nurse is going into the partner or the universities, and the other nurse actually goes in the unbranded vehicle together with the linkage officer who does the testing. And we go to their workplaces, we call them, we have a list every day to say, okay, today we are going to 10 people. Hi, our case manager actually calls, hi, you know you're booked for PrEP CT. Are you able to come into the facility? No, I'm not able to come. Do you mind if we come to your workplace? Yeah, sure, I work in Woolworths. I can meet you outside for a couple of minutes during my lunch break. And that's what we do, and it really, really works, because a lot of our young girls are out there working. They are not able to get time to come into the facility. So that's what we do. Thank you.
Okay, good afternoon. Thank you, the panelists. My name is Moronga Dikgang from USAID Botswana. Sorry I missed your name. Yeah. At the height of COVID, we once did a little survey on access to internet for adolescent girls and young women. So I was wondering if your application, is it internet-based? And if yes, are you aware of any models that are available that use non-internet kind of platforms? Because we might leave other girls behind or other users behind who do not have access to internet. And then the other one is for Dr. Naidu. The co-location part. From the presentation, I interpreted it to kind of drive new PrEP initiations. So I don't know if you use the same modality also for PrEP refills, for PrEP review, which will be similar to what the Belobelo colleagues are doing. Thank you.
Thank you very much for your question. With regards to online, offline usability of the application, for the application developed in Vietnam, it is an online-based application that does require internet connectivity, whether it be through Wi-Fi or through a data plan. There are certain features that can be, and that we want to integrate an offline approach. Now, I had mistakenly initially presented the presentation with Mozambique, and the reason for that is I had also done some work in Mozambique to develop a platform that was used more for operational purposes that did have an offline component. So the technology is available for you to have offline communications to allow for those features. And then once you get back to a Wi-Fi connection, it will automatically upload that information through, but still allow you to utilize some of those features during the offline periods.
So thank you for that question. So we do provide appointments. So once we initiate in the community, then we do provide the client with an appointment to come to return to the facility for continuation. And to ensure that they do that, we do call them. So we do a little bit of case management, we remind them of the appointments, and then if they don't come back, we track and trace. It's just because of the vast space and the geographies. Otherwise, it's a great idea what Botswana is doing. If you have large numbers in one place, then to make a return visit to do the refills then.
Thank you so much, everyone. And I really appreciate, I do know that there are more comments and questions in the audience, but our time is up and there's a big red flashing sign at me right now. So we have to change for the next session. Thank you all so much. One more round of applause. Thank you.